Hello and welcome to my case study. My name is Janice Woodard and my case is on abdominal aortic aneurysms, better known as AAAs. This is for sectional anatomy for medical imaging, RAD 310, and it is spring of 2012. Just a brief description of a AAA. It is a local dilation of the aorta within the abdomen. It's a weakening of the wall of the aorta. This is abnormal and is permanent even if you have surgery. The picture on the right shows, you can see how the aorta isn't smooth like a vessel should be. And in the lower abdomen, right at the bifurcation, you can see this bulge. This is the aneurysm. And you can also see in the common iliac arteries here, there's also another aneurysm. Just some images that I found. This is a coronal image of a AAA. In this image you can see in the lower abdomen there is a large aneurysm here. And when doing a CAT scan for AAA, you want this what they call a candy cane appearance. This arch and then all the way down. You want to see the ascending aorta, the arch of the aorta, thoracic descending aorta, and the abdominal descending aorta. What I'll talk about a little bit later is you can see how that aorta is protruding the abdomen just a little bit, and I'll go over in detail a little bit more later about that. This 3D image, you can see where the aorta is in relation to the kidneys, where the renal arteries come off of the aorta. This is a fairly large AAA, and you can see how the common iliacs are also dilated. The axial image, you can see the outline in blue. That shows the aorta itself. That contrast goes through, as you can see, is highlighted. And the red portion is where the aorta is. That's how far the walls of the aorta have weakened and expanded. The etiology of a AAA, it is thought as a degenerative process of the aorta, but the cause, they're still unclear on what causes a AAA. They have some risk factors that they found, but no specific cause. So risks include smoking, genetics, atherosclerosis. Sometimes it could be caused by an infection, trauma. The epidemiology, a male that is 60 years or older that smokes, has hypertension, atherosclerosis, and a family history of an aneurysm are the most likely to have a AAA. Some statistics that I found with AAAs: men are 4 to 5 times more likely to have a AAA than a female. Males, their increased risk starts at about 50 years old, but kind of decreases around the year 80 years old. For females, on the other hand, their increased risks start at 60. It's a little bit later than females, or for males, but they do have an increased risk at a later age. It's estimated that there are 15,000 deaths per year secondary to AAAs. Smoking is the greatest risk that they have found, but they say depending on when you quit, the risk can slowly decrease. For example, my grandmother decided to smoke up into her 50s. She decided to quit. Within the last 5 years they found a AAA and they have fixed it, but she didn't quit soon enough to decrease her risk. They found that a AAA is the 10th leading cause of death for males over the age of 55. And the most interesting fact that I found is ethnicity, like other pathologies, they found no link to any increased risk. They have found, though, that it is uncommon for African Americans, Hispanics, and Asians to have an aneurysm. Some signs and symptoms. A AAA is known as the silent killer. It's most likely going to be asymptomatic. No symptoms, it's just going to happen, and you won't know what hit you. But some people do claim to have symptoms. Some symptoms include back pain, which may be constant or on and off. Some radiating back pain. The pain will radiate down into the buttocks, groin, and legs. And the most common symptom for a AAA is a pulsating abdominal mass. This is when you go into your physicals, yearly physicals, the doctor's pushing around on your abdomen. They're checking for a mass within the abdomen that has a pulse, which could show signs of an aneurysm. Once the aneurysm does rupture or burst, you can get a severe sudden back pain and abdominal pain, paleness, dry skin, dry mouth, a sudden need for water or fluids, nausea, vomiting, and signs of shock, such as shaking, dizziness, fainting, sweating, sudden weakness, rapid heartbeat. This is one of the most important signs to find when you're assessing for a AAA, because if they're not into shock yet, that means that there's a better success rate in treating them before they actually lose life. Treatment options. There are 3 treatment options that I found. The first one is what they call watchful waiting. This is when an AAA is 5 centimeters or about 2 inches in diameter or less, and these have low risk of rupture, even though they do find some that do rupture. Basically, you go and see your vascular disease specialist and get routine ultrasounds to show and record how big or how your aneurysm's getting. The second one is surgical repair. This is most common in large unerupted aneurysms. This is an open surgical repair by a vascular surgeon. This procedure is very hard on those who have vascular diseases, heart failure. What they do is they clamp off the well, first they make an incision from the xiphoid down to the pubic bone, so it's a pretty big incision. And then they go and they cut open the aneurysm. Well, then before that they clip the top of the aorta off, therefore causing more pressure on the heart. And they basically sew a graft in there, so it kind of bridges or makes a tunnel inside the aorta to where the blood can pass, and there's not that pressure on the aneurysm. The last is a interventional repair. With the interventional repair, this is for those who have increased risks such as heart failure, and that aren't so much going to, it's for people who are in their 70s, 80s, those who aren't going to live past another 20, 30 years. because with this procedure, they don't know how long these grafts last. What they basically do with this procedure is they make an incision in the thigh. They take a catheter and they put it in the femoral artery, and it's fed up through the artery into the aneurysm, and then the graft is then opened, creating new walls into the blood vessel to what it's basically what I described in the surgical repair, but it less invasive, goes through the artery rather than cutting open the whole abdomen. Some disadvantages to this: they don't know how long the graft lasts, and therefore they don't want to do this procedure with younger patients with AAAs. And the grafts aren't custom built, so depending on what size you are, they only have a certain range of grafts and stents that they can put in. One complication with my grandmother is she already had one kidney that wasn't working properly when they found the aneurysm. When they clamped the aorta off in the surgical repair, they clamped the renal artery, so now that artery does not function properly. Therefore, she has lost both kidneys and she is on dialysis. Now, this may be because of the aneurysm, or it could be because of the surgery. We're not sure. And my computer stopped working. One moment. Sorry about that. I don't know what happened there. For prognosis, if caught before it's ruptured and surgically repaired, there's about a 90% full recovery. Now, if it's ruptured, the chance of survival is very low. I did find some statistics that 50% of patients that come into the ER that have a ruptured AAA only have about a 50% survival rate. Now, those who do get past the ER and into surgery, their rate of survival drops by 1% per minute. Therefore, it's critical to assess the patient and get them to surgery as soon as possible. And I did find, like I said earlier, if a patient is not in shock, their rate increases on the chance of survival. And that is it. This is my Works Cited page, and I hope you enjoyed my presentation. Thank you.